And now I talk about the combined peripheral and central vestibulopathy. It is quite interesting topic. I started a few years ago. So the main concept at the time was that with the head impulse test and the development of neuroimaging, so now we can securely diagnose the peripheral vestibulopathy and central vestibulopathy. But as you know, the neurologist usually doesn't know anything about inner ear, so that's the problem. And the ENT doctors mostly afraid of the brain. So in case of combined peripheral and central vestibulopathy, they only see what they want to see. So for ENT doctors, if they see some peripheral patterns of vestibulopathy, the positive head impulse test and unidirectional nystagmus, oh, this should be vestibular neuritis. And in the other side, the neurologist only focused on the central side, and they frequently missed the peripheral ones. So that's the point I started this research. So it's very simple case. A 63-year-old woman presented with acute vertigo and hearing loss and tinnitus. She had dilated cardiomyopathy, and if you look at the spontaneous nystagmus, is horizontal and torsional, and a little bit of upbeat component, which suggests that more involvement of the superior division. So when you look at the spontaneous nystagmus, there is upbeat component. There is more involvement of anterior canal compared to posterior. If both canals are involved equally, there should be no vertical component. So if there is a upbeat component, it might be more to the damage to the superior division. So let's look at the. You can see a little bit of left beating nystagmus with visual fixation, a little bit torsional, and without fixation. Nystagmus build up, increased without fixation. So until the findings are quite of damage to the right inner ear again. And she also shows right caloric paralysis and complete hearing loss on the right side, decreased formation, amplitude of C-vamps, no formation of ocular vamps. That indicates damage to the whole vestibular compartment and cochlea on the right side. But again, during the bedside evaluation, I couldn't detect the gauge-evoked nystagmus, but I found this direction-changing gauge-evoked nystagmus that's so subtle. Gauge-evoked nystagmus beating to the right during rightward gaze, and also left beating and nystagmus during leftward gaze. Now, diagnosis? Yeah. Only ICA infarction can make this kind of a presentation. So, in patient with, as I stressed before, in patient with acute unilateral combined audio or vestibulopathy, you should look for the central signs, and there is a central signs. You can diagnose ICA infarction right away. So that's the tip. So ICA infarction is the most common cause of acute unilateral combined audio vestibulopathy. So this is the case that I showed before. So this is the reason. So if there is, even when there is obvious peripheral sign, you should look for the central ones thoroughly. Without that, you may miss the ICA infarction. You can image, but it's totally different when you got central signs and you are so confident with the ICA infarction diagnosis. You can easily persuade the patient or the medical staff in your hospital. But isolated peripheral signs of audiovasculopathy, it's just kind of a gambling, something like that. And as I told you before, the hinge may not be enough to detect central lesions in ICA infarction. So sometimes you need careful follow-up. This young man with uncontrolled hypertension for a couple of years presented with acute isolated vertigo but no hearing loss. And you can see without fixation, it's a strong left beating nystagmus, but the nystagmus is mostly suppressed by visual fixation, but you can see the change of direction of nystagmus during rightward gaze. So same situation, but in this patient, no hearing loss. That's the difference. So combined peripheral and central vestibulopathy, but without hearing loss. That's the key point in this patient. And positive head impulse to the right, a little bit suspicious, but to the right is obvious. And he shows right caloric paresis, normal hearing, decreased cervical vamps, and no ovum formation. Isolated vestibulopathy again, but with gaze evoked nystagmus, obvious central sign. And we measure the head impulse using the magnetic search coil techniques because we are a little bit suspicious on the head impulse test to the left. And we found that the decreased gain to the right, but also decreased gain to the left. So the head impulse was impaired in both directions, but more to the right. So where is the lesion? ICA. But I told you before, the most common presentation of ICA infarction is both audio and vestibulopathy, combined audio. PICA. Then why the patients show the head impulse test in both directions? I told you that the only folliculus can cause head impulse test in both directions, but in this case, not follicular infarction. We know that because the other findings of peripheral vestibulopathy, so we know that this is not from the isolated follicular damage. Any other thought? The MRI was normal. Again, indeed, this patient was transferred to me from another hospital, nearby hospital, because they got panic with this normal MRI. So you should go to the Professor Kim. So I just told my resident, just wait, and we're going to rescan him several days later. And we did 4 days later, and the lesion is here. I exactly expected at the time the lesion should be in the vestibular nucleus. So this is the area of medial vascular nucleus, because you know that the vascular nuclei is the only place where the peripheral inputs and central modulation, emerges combined. So it's quite strange things is that the another patients came several days later, so we decide to analyze the previously reported patient with isolated vascular nuclear infarctions, and we recruited 9 patients, and as you can see here, most patients with nystagmus beating to the intact side, except this patient. And as I told you before, I suspect the lesion is not the vascular nucleus, and the other structures, inferior cerebellar peduncle, because lesions involving the inferior cerebellar peduncle cause ipsilegional spontaneous nystagmus. So we can't differentiate the vascular nuclear involvement and ICP involvement only based on the MR findings. As you can see here, most patients showed gauge-evoked nystagmus, and in the other patients, they did only a bedside head impulse test and found only ipsilegional impairment, but with recording, we documented bilateral impairment and caloric paresis on the lesion side. So second lesson here is that the lesions involving the vascular nuclei may present with combined vasculopathy, combined peripheral and central vasculopathy without hearing loss, and may be isolated. And in vascular nuclear lesion, the head impulse test may be impaired in both directions, maybe due to commissural impairment of the commissural modulation between the nuclei. And I'm stressing this all day. Don't be fooled by the MRI and just follow up, or even though the follow-up MRI is normal, don't get panic. Just treat them as you think. It's another patient with dizziness and ataxia, but it's chronic course, slowly progressive, and the patient shows spontaneous nystagmus along with gauge-evoked nystagmus. What is your prime suspicion? Slowly progressive ataxia with spontaneous nystagmus and gauge-evoked nystagmus. What kind of cerebral lesion? Why there is this spontaneous nystagmus horizontal? It may be, but it may be. Any other? CP angle tumor. No, CP angle tumor is the most common cause of chronic unilateral combined peripheral and central vasculopathy. Usually, peripheral vasculopathy on the lesion side with gauge-evoked nystagmus, sometimes Bruns type. You see this patient with chronic imbalance. You can see the right beating nystagmus without visual fixation. And gauge-evoked nystagmus during leftward gaze. Direction change in gauge-evoked nystagmus, along with spontaneous nystagmus. And she also shows hearing loss and caloric paresis on the left side, and no BAMS formation during left ear stimulation. But if you look at the head impulse, positive to the right, but also positive to the left. Even though the right-sided head impulse is more obvious, Then it can be possible in CP angle tumor, head impulse test, positive in both directions. Is it possible? Yes. Why? Yeah, compression of the flocculus. I told you before, the floccular lesion can cause impaired head impulse test in both directions. So when we recorded the head impulse, the decreased head impulse gain in both directions, and indeed the patients showed huge CP angle tumor compressing the cerebellum. So another lesson here, when you suspect CP angle tumor and when the head impulse test is positive in both directions, it should be huge. It should be huge, compressing the cerebellum. And after this patient, we recruited about 20 more, and we correlated findings of head impulse with tumor size. And we got good correlation of decreased head impulse gain to the lesional side and tumor size. And typical history, this is typical history. Heavy alcoholics, poor nutrition, and developed a sudden imbalance and some kind of, the mental change. No spontaneous nystagmus. But there comes gauge-evoked nystagmus on looking into the side right beating during rightward gaze, and you can find left beating nystagmus during leftward gaze. Head impulse. It's positive in both horizontal direction. What is your diagnosis? Yes, it's Wernicke encephalopathy. So Wernicke encephalopathy is most common cause of acute bilateral combined peripheral and central vestibulopathy. So why there is a combined lesion? Because Wernicke typically involves medial vestibular nuclei, also inner ear too. So at the time when we published this paper, we had 2 patients and complete caloric paralysis. And sometimes ICA infarction may be bilateral because, basilar artery supplies both ears. So there is a thrombus near to the orifice of both ICAs in basilar artery that may cause inner ear damage and to the central structures on both sides. And in this case, acute bilateral combined vestibulopathy, as I told you before, you should be fooled by the infarction, acute infarction involving the vestibular nucleus or flocculus. In case of vestibular nucleus, you can get unilateral peripheral impairment, even though the head impulse is impaired bilaterally. In floccular infarction, you can get bilaterally impaired head impulse test, but no signs of unilateral peripheral vestibulopathy. That's the differential diagnosis point. And this old lady with chronic imbalance, no spontaneous nystagmus again. but gauge-evoked nystagmus. And head impulse, positive in both directions. In this case, chronic, progressive imbalance. So what is your diagnosis? With bilateral vestibulopathy with cerebellar symptoms. And if there is combined peripheral neuropathy, we can diagnose canvas, cerebellar ataxia, vestibular areflexia, and neuropathy. And if there is no evidence of peripheral vestibular involvement, then CAVA, cerebellar ataxia and vestibular areflexia syndrome. But see this patient with bilaterally impaired head impulse test. But this case, she had a mutation of SCA6. So I'm not sure whether you are familiar with this type of cerebellar ataxia. The SCA6 is known as the poor cerebellar form of spinal cerebellar ataxia. But why the patients get this bilaterally positive head impulse test? We still don't have any definite answer, but it may be from the involvement of the flocculus or the forecerebellar form. The definition may be incorrect. Indeed, in the autopsy cases, in the advanced autopsy case, there is evidence of peripheral vestibular involvement in SCA6, but we should differentiate, CAVA or canvas. When you see the patient with cerebellar signs and head impulse test, you should think about the possibility of SCA6. And again, in this patient with bilaterally impaired head impulse, the calorics are symmetric, normal, and rotatory chair test were also, the gains were normal, only impaired the gain during head impulse test. So again, there's dissociation in the abnormalities of vestibular ocular reflex in this patient group. So this is the conclusion. So in patient with combined peripheral central vestibulopathy, as I told you before, ICA when acute unilateral, and CP angle tumor when chronic and unilateral. And when acute bilateral, think about the Wernicke, and in chronic bilateral cases, you may think about the degenerative condition, including canvas, CAVAS, and SCA6. So even in the patients with acute vestibular syndrome and positive head impulse test, I'm emphasizing again, you should look for the central signs thoroughly, not to miss ICA infarctions. And in patients with central lesions, the positive head impulse test doesn't necessarily indicate combined peripheral damage, because the vestibular nucleus or a floccular lesion can cause impaired head impulse test. And in central lesions, the visual performance may be dissociated according to the stimulus frequency. So dissociated findings during head impulse and caloric test and rotation and test. And again, hints isn't almighty in detecting central lesion in this group of combined peripheral and central vestibulopathy. Thank you. And this is my last section. So I'd like to remind you the upcoming Bharani Society meeting next year in Seoul, early June, and hope to see you all in Seoul next year. Thank you very much.